All right, I finally have my Dr. Meghan Jones on the show today to dive in about looking at a genetics and our blood chemistry panel and other functional lab testing helped figure out what we need to do today to be our best self in the future. And I asked Dr. Meghan to come on to share what she does and why. And we're going to go over my results that I did last couple of years and help use myself as a guinea pig
Yeah.
example of what we're doing over here. So thanks, Meghan, for coming on to talk about how we can be our best selves in the future.
Yeah, thanks for having me.
So I love, as I just was telling you, I'm going to ask you,
Yeah.
what do you do and what's your why? Love to dive into your purpose, your mission. Let's get started with the what drives you.
Yeah. Yeah. I had my background is I was trained in emergency medicine, which is, the Wild West in some ways, and lots of like practicing reactive medicine, like super important, but was really yearning for doing a little bit more, prevention, for sure. And I kind of been working on my own health and my my dad at the time, kind of through most of my med school years, dealt with a lot of heart disease and kind of was always getting stents and things like that. It culminated in attempting a heart transplant that didn't work out. So he passed back in 2021, and around that time, I was kind of starting into a training program with Wild Health at the time to do precision medicine. And just as you like check your own genetics and all of these things, you just start to think like, man, if our family members or people we know are suffering with things that had some of this genetic insight 20 or 30 years ago, like how much different of a story would this be? So
Mhm.
that kind of took me, helped me fall in love with and really move into this more precision medicine, kind of using genetics and doing more preventative care.
How would you explain what Wild Health Precision Medicine is? What are they
Yeah.
doing?
Yeah. So we're basically getting as much of your data as we can. Like we're looking at things like biomarkers. I think the big thing we do a little bit differently is looking at your genetics and kind of genetic variants,
Mhm.
especially as it pertains to different pillars of health, like nutrition, exercise, sleep, and really helping us tailor, preventative care, longevity, chronic disease prevention. And then adding in, kind of based on person to person, like what other information can we get to really build kind of your own personalized, or precise, um, plan, to really
Mhm.
just, like you said, be our best selves. And that could include, things like gut health testing or heart imaging, full body MRIs, like you name it, we can kind of dive into it depending on what people's goals and symptoms are, if any.
Do a lot of your patients come to you at Wild Health that are being health optimizers, or are they already ill trying to get healthier?
Hmm. Yeah, I think we have a really good mix. Like we have people that kind of, are seemingly like picture of health, but they really want to get that nth degree and like, really optimize, make sure they're doing all the things and having somebody that helps check those extra things, that they want to hit and just live as well and as long as possible. And then definitely on the flip side, we have the other end of that spectrum where somebody's maybe been struggling with, either something known or oftentimes like really can't find a diagnosis. We have, maybe vague symptoms or like autoimmunity and things like that. Um, and just really kind of searching to what are extra information, what's the extra information we can get to kind of help either figure this out and or, optimize, and just feel better. So I feel like it's definitely this big mix and then like everything in between there for
Yeah.
sure.
I feel that I'm, as I get older, on a mission to get people to understand in your 50s, you should be really taking action and getting
Mhm.
all this data now and not waiting until you're in your late 70s going to the doctor for all these different health problems. And I really
Right.
wish everyone would, it's almost that you need to invest in your health for longevity for the future you program, I'm calling it.
Yeah,
Instead of just putting all your money in your 401k or your savings or however you're investing for your future, your retirement fund.
for sure.
But I think part of that should be going to doing stuff now, figuring out, okay, what do I need to do to set myself up for success so I can go to Positano when I'm 70 years old
Yeah.
and walk the hills?
Yeah, absolutely. It's kind of, and it's a lot of forecasting, right? Like, what do you
Yeah.
want to be doing at 70? And this is like, I mean, you can definitely liken it to a 401k, right? You're like, I want to hit these numbers by the time I'm retired. I would say similarly, like, I want my bone density and my muscle mass to be X, Y, and Z, so I
Hmm.
can do those things when I'm, you know, hitting hitting my retirement. So,
So I think a lot of people get scared of looking at genetics. They don't want to share their data. They
mhm.
don't want to know. What do you find is kind of holds people back from looking at their genetics? Have you?
Yeah, I think that's definitely like I would say in one vein, folks definitely worried about what gets shared, where are you sending this? And I can only speak for ourselves. We like, run data with LabCorp. Like we don't sell anything, we don't give your stuff away. Everything's kept under HIPAA and confidential. I would
Mhm.
say the flip side of that is people are really concerned about what they might find out. And afraid that's going to put them in a almost like a place of fatalism, like, oh well, I know I'm going to get dementia now or something like that. So I've had people really scared, and even some people ask like, can you leave out like my APOE status?
Mm.
Um and I think folks, yeah, I mean, and understand, it can be a scary thing. I think a lot of, what we check, we're doing those genetic variants. So it's, there's a lot of like blueprints, but nothing we're checking necessarily is like giving any stamp of fate or
Mhm.
dictating what'll happen. And then I think I often tell people like the things we're checking, help us know, and I think help us give buy-in to like, what are we going to change about our current lifestyle? What are we going to add in? Like myself, if I knew I had an ApoE4, I'm probably going to skip the extra glass of wine at dinner or at
Mm.
the barbecue or whatever. Um, just knowing like for me, it's probably not going to serve me anyway, but definitely, may lend itself to being more harmful, knowing I might
Mhm.
have predisposition to chronic disease.
Well, that's what I think helped me is when you get the labs. And plus, I did a Vibrant Wellness wheat Zoomer test a few years
Mm,
ago. And that really helped me go, I need to avoid wheat in the
mm,
US at least all the time
yeah,
because I just saw my markers going, wait, I think of brain health and cognitive decline and a leaky gut, leaky brain, that really set me going, okay, I have non-celiac gluten sensitivity and all my genetic markers will look at. And
yeah,
that motivates me to stay off of it, be strict versus other people like, oh, I'm kind of avoiding it. And it's not that gluten's always bad. I think it's more in the US and
yeah,
in Europe. And understanding what that might help, avoiding or doing things differently, changing your lifestyle habits now so I can be thriving as I age and not struggling. And the mental health is really what I think more focused about because this cognitive decline to dementia to
mhm,
Alzheimer's to Parkinson's, I think that's more scary than anything
sure,
else to lose your mind and
for sure.
struggle with that. What do you think?
Yeah, I mean, I think that I would say that's one of like the bigger fears most of folks come to us with. Either, and a lot of times like they've seen a loved one struggle with that, or they've been a caretaker, care provider for someone in that. And I think there's this idea that, maybe if things happen to our bodies, we obviously can have a little more awareness and um ability, to do something about it versus if our mind starts going, we may not even know, or by that point, is it too late to be able to participate in changing anything?
So you lost your dad in 2021. My dad passed away, heart disease and kidney failure and
Mm,
all this stuff combined in the following year, June 2021.
mm.
Your dad, you're younger than I am a lot, I think. But how old was your dad when he passed away?
So I think he was 64. Yeah, it was just before his 65th
Yep, so
birthday.
my
And he
dad.
had already outlived his dad by like 12 or 13 years by that point, from heart disease as well. So that
So
was
what
another
if,
kind of a
yeah.
motivator to kind of look a little closer at my own genetics for sure.
And what have you learned as you take a deep dive into what actually causes heart disease? What have
Yeah.
you found in your
Yeah.
journey?
So I think it's been, a really interesting learning curve from some of my traditional training. I think we hear about different things. I think a lot of emphasis has been put on cholesterol. Um, and what I'm finding is that's just, really one piece of
Mm.
the kind of pie chart, right? That is our heart disease risk. So, cholesterol, yes, those are like the particles that get deposited there, but, we need kind of a ripe environment for that plaque to cling and stay there and continue to build on itself. So whether that's, like a higher blood pressure that kind of roughs up the insides of our blood vessels and, creates some of that like endothelial disruption, or what other things are causing inflammatory processes, and like that's causing an environment. And a piece of that also being we know we can be predisposed to things through our genetics as well. And there are lots, they've done some big studies that and found genes that are seemingly correlated with that. But really that's just, the one piece. And then we have cholesterol and inflammation um and our, our lifestyles too, right? And sedentarism and all of
Mhm.
that. So I think more than anything, I've found that there's lots of factors. Some we can control and some we can't. And it's definitely a bigger picture than just our total cholesterol, or just our LDL cholesterol for sure.
Yeah, I was just asking that because I did an interview with Dave Feldman, who did this whole study on lean mass hyperresponders and
Mm,
getting into what they found, and then looking at other videos on YouTube, doctors, was it Doctor Safe Doctors or some Doctors by Doctors or something channel of all these different videos of
mm,
people, medical doctors that were cardiologists that shifted into not work. They are still
yeah.
cardiologists, but shifted in out of traditional medicine, saying everyone high cholesterol needs to go on statin drugs, and looking at the negative effects of statin drugs, as I just heard about dementia on it, if you're on
Mm,
it too much, and then pushing cholesterol. I know someone's getting their doctors trying to get them on double statins, push their cholesterol down to 50.
mm,
And it makes me frustrated, and I'm not an expert, but just to share, here's what the research is saying currently. Let's not go back into the research that was maybe not 100% accurate, that came from the 50s, and really look at the whole picture, as you're saying, the nitric oxide production, endothelial health of the lining of the blood
mm.
vessels, insulin
Right, right.
resistance, oxidative stress, and all these other things that people are still looking at total cholesterol, not the LDL particle size,
Yeah.
and other markers that we'll go into is homocysteine and A1, or not A1C so much as fasting insulin, and
Mhm.
what are the other ones? Looking at triglycerides and fasting insulin and all that. But it's frustrating that people are still taught in accurate, outdated information in medical school. Do you find
Sure.
that still common when you're researching?
Yeah. Yeah. And I'll say, I have like currently not a ton of ties like in the academic world to know like exactly what's, being taught today in class. But I feel like there is this trend of usually what's being taught is probably, that like in that 5 to 10 years behind what's kind of happening on like the cutting edge studies that are coming out. And understandably, you're going to have, it's going to take some time to trickle down, but um, and I think the pace at what we're, onboarding stuff is, I'm sure, much, much faster than we've ever done too. Uh,
Mm.
so yeah, I do think that there's, whether system reasons or not, there's definitely a lag of what's being taught for sure.
So that's why I wanted to share. We can share my
Yeah.
report. And I think diving into looking at what we can do now to learn about our family history, our genetics, and the role of epigenetics, and
Mhm.
what we can do in middle age to help our future self
Yeah.
be healthier and doing what we can do, knowing what we can get from these labs.
Yeah,
So, do
for
you want to, can you
sure.
share?
Yes. Get the
Because
right tab here.
I just love the report since I took the program
Yeah.
a year and a half ago. But when I was in Ben Greenfield's Keon coaching program, we were beta testing, I think, when they first started doing the Wild Health genetic reports. and learning from Matt and the team, but I think it's just the layout of it is really helpful. Can you
Yeah.
expand that at all? Or is it my side? Let's see.
Yeah. So like make it a little bit bigger. Is that better?
Mm-hmm.
Okay. Yeah. So this health report, kind of brings in and combines most of, a big number of our biomarkers. We have other that we check that aren't always integrated um, in this report. And then our DNA, so our genetic SNPs or those polymorphisms. And then currently this version, can pull in some microbiome testing if people have done that as well.
Okay.
Just so it like makes it this nice, pretty PDF we can continue to reference and have as
Yeah.
a roadmap.
I just ordered mine. Well, it's on my list today. I put it in my shopping cart at Rupa Health to do the GI map.
Oh, nice.
I
Yeah.
need to add that in.
Yeah. And so with this report specifically is kind of broken down into pillars of health. So our nutrition, exercise, sleep, neurobehavioral, and then the bottom half of the report, different genetics around chronic disease risk. And so most of it, you're going to have this report has like little things that are going to be good for all of us, right? Like eat real food. And then also each section with these genetic variants. So, think of we kind of do this color coding like DNA, you get copy from mom, copy from dad. Anywhere that we see those green boxes is where we got two normal copies of that gene. Anywhere that's yellow is one normal copy and one of those variants or those single nucleotide polymorphisms. And then anywhere that's orange is where we got two copies of that gene. And so we know that, there are very few times that any one gene is going to carry all the weight in causing something. So we can take groupings of genes with similar functions and make these polygenic risk scores. So kind of the dials up here, giving us kind of like an overall average. And this first section is looking at, are there any big macronutrients we might have more genetic intolerance to? And I think, really for you, you're kind of had a little bit of moderate risk across the board here. And some of these, the ones shown in here, there are more genes that are checked in these polygenic risk scores, but these are some of the little heavier hitting ones. Um, and so but we pair that with what are labs saying here too. So we knew for you when starting out that LDL cholesterol was a little bit higher, your ApoB was, I think just above an optimal goal. So kind of like going over here, like, okay, well, for saturated fats, you had a few copies of these PPAR alpha genes. This could carry a little bit more weight in increasing cholesterol if you had a diet higher in saturated fat. Like you might just be a little bit more sensitive to that contributing to cholesterol. So we'll often talk to people about, can we look at where we are, maybe reduce saturated fat intake to less than 25 grams a day, and kind of pairing that with, we want to increase our fiber as well. But really, and then for you, you had, a decent overall tolerance to, fat overall, or like more of that unsaturated fat. And I know you've, talked about noticing some sensitivity to carbohydrates. I think from a genetic standpoint and having several of these like FTO genes, um, these are gonna, showing you some of that sensitivity is going to be to more like refined sugars paired with trans or saturated fats as well. Kind of we can probably all do with a little less of those, but
Mhm.
kind of a bigger kryptonite food for you. And we had also kind of talked a little bit about that. You had great, great fasting glucose and fasting insulin, but just a little bit higher
Mhm.
A1C there as well.
That was
Um,
weirdly high. My A1C when we
yeah,
started came down, but that was
yeah,
odd because I don't eat processed foods and I don't eat the trans fats
yeah.
and all that, but just how other influence, what else influences our A1C
Mhm.
besides processed food, high sugar, carb diet?
Yeah. And definitely we can dive into like, are we in a high stress state? Are we having like high cortisol that can lead to higher blood sugar, can lead to higher, insulin and A1C. And I think for you, maybe and for a lot of folks will like we might see some of these out of whack and we talk about like wearing a continuous glucose monitor and can we really dial into times we might be seeing either a bigger spike or a longer lasting spike. And even behavior wise, right? Like I've had people wear it and they're like, my sugar's really high at work, even though I'm eating the same thing as when I'm at
Mhm.
home. So it's always really interesting to get some of those insights to kind of pair into that data folder too.
That's when it's fun to learn how to respond to stress with CGMs and how to do the, more of the breath work, the 4-7-8 breathing
Mm,
or the box breathing, and really tie that in, how I become more resilient. And be interesting to correlate am I increasing my heart rate variability, improving my vagal tone? Is that showing a difference in my blood sugar levels, my A1C? So
for
by just
sure.
working on stress management with that vagus nerve, be interesting relation.
Yeah, for sure. Yeah, I've definitely had people that like kind of set, like an intentional, like I'm gonna do this breath work or this meditation and absolutely seeing, trends on their CGM come down for sure.
Real quick on the saturated fat to trans fat, what would you classify as a trans or a saturated fat? Because usually we hear more ancestral fat, saturated fats from animal meat. If it's grass fed, it's a good, clean source of
Mhm.
fat. But what do you say is when you have these different genetic SNPs that you may not be able to tolerate as much saturated fat? Is there more specific breakdown of what type of fats that would be not ideal
Yeah.
for someone?
Yeah. And we definitely, we talk about, and honestly, one of the kind of ways that Wild Health was initially founded were our two founders, they were kind of, they do like experimental diets and then check their biomarkers. And I think they both did keto for a while. And one of their cholesterol like went through the roof, one stayed just fine. And so looking at, absolutely like real, real whole foods, like animal fats, especially fully grass-fed animals and all of that, they're gonna even like the grass-fed, like say red meat, it's gonna end up being a little less saturated fat content than say that same cut of red meat, but in a feedlot animal.
Mhm.
Um, and you know, we definitely want that emphasis on like real whole foods, but then the amount of that is going to change person to person who can tolerate it. So, it's a big fight in my household. Like I have a lot of these genetics. I really can't tolerate a lot of saturated fats without my cholesterol going higher. So we're doing less butter and less red meats and less full
Mhm.
fat dairy. And my husband is constantly asking, like, can we maybe do steak once next week? It's like, I don't have these.
But what
Um,
about, so this is what I just talked about the Dave Feldman interview. That's interesting to compare with for your stats is they're saying more it's looking at the triglycerides, LDL particle size and not
mm,
looking at the total cholesterol, but
right,
just
right.
that small dense and looking at soft plaque, getting the scan. So,
Mhm.
their study was on keto people they're the lean mass hyperresponders that had LDL levels up to 400 to 500, and
Yeah.
they did this whole study last few years and doing the scans and look at plaque regression. And it was interesting data that they collected on people that are eating a higher fat. If they have more of the genetic disposition, the other markers to look at is fasting insulin, the CRP,
Mhm.
as we said, the triglycerides, oxidative stress markers, that
Yeah,
it's not to be just looking at the total cholesterol. Have
absolutely.
you found correlations with your own investigation?
Absolutely. Yes. And I will say, I will give the caveat that I personally haven't had like a clearly scan yet.
Oh, that's the one
But
not to do though. That was a whole
yeah,
study. They just
yeah.
announced and they're trying to secret put it out there publicly, but they did 4 different scans. The
Hmm.
3 were always consistent, clearly was not consistent at all. So they're getting
Okay.
a bad
Yeah, I
rap
haven't
now.
seen
So
that one
don't
yet.
suggest it just came
Yeah.
out.
I'll have to yeah, I have not seen that one yet.
I'll send you the
Um,
YouTube video. It's huge.
but like along those lines, like I hadn't, or insert any imaging, I had not had yet. And I think it was like knowing my genetic risk, my family history. Like I just chose like I'm gonna, work hard on like lowering that like LDLP and my ApoB.
Yeah.
And I also had like a slightly higher LP little a, and that one's like pretty heavily genetically linked.
Mhm.
Hard to, um, you know, pretty hard to move. Like CoQ10 and niacin might help a little bit. Um, but absolutely, like I've had people that super high LDLs, ApoB, otherwise like normal inflammation, like very active. We've gotten whatever scan and they've got zero plaque.
Yeah.
So it's hard for me to make a case of like we should be really aggressive on this when you really otherwise don't have like that genetics and environment that's allowing this higher LDL to take hold. So, and I think that's where that precision medicine allows for a lot of that. Like I don't have to just based on our biomarkers before we get everything back, just be like, oh, your cholesterol's
Yeah.
super high. We're going to start a statin today. And I think it allows for a little more nuance for sure.
Mm-hmm. Yeah, because looking at triglycerides. So that with the nutrition part here, so this is why I think is very valuable information to figure out what is the best food plan for you based on
Hmm.
genetics, and then also learning about how food makes you feel. What else do we have? I know the next couple pages are on food. We can kind of scroll through because
Yeah.
it's 50-page report, but
Yeah.
what
It's
else do
thick.
you learn
Um,
about what's best for me, Debbie Botts, to
yes.
eat?
Yeah. So I think, we talked about probably like a little lower saturated fat, still having good, unsaturated fats, like more of that like
Olive.
Mediterranean-ish, right? Like olives, avocados, more lean proteins. Um, we can look at things like around your methylation, so how we're just moving some of those little methyl groups around, kind of turning systems on and off.
Mm-hmm.
But methylation having a big hand in our hormones and detox pathways and brain health and chronic disease. And we have two different pathways that we can methylate through. And so, one's a little more dependent on choline, one's more dependent on these B vitamins. Actually, this is a little better picture of it. And
Can you
so,
explain methylation? Is that a
yeah,
simple way to
so
explain it?
yeah, right. So I like to tell people, we have just like think of a little carbon molecule with some hydrogens on it. When our body kind of tags that to different things, whether that's like the system that builds hormones or the system that gets rid of toxins or, really has its hand in a little bit of everything, it can kind of help turn that system on and off. It can ramp it up, it can slow it down. And so, they're finding more and more like if this methylation is less efficient and we get these really high levels of homocysteine build up because we're not using it up in those cycles, we're seeing that correlated in, more progressed chronic disease states. So heart disease, cognitive decline, dementia, diabetes, things like that. So that's kind of why we care about lowering homocysteine or improving methylation. Um, you also hear about methylation kind of in that like epigenetics or like even turning genes on and off and how we express things. And so we can look at some of our genetics around that and say like, okay, are we more predisposed to one or both of these cycles running less efficiently? And so when somebody has, our goal homocysteine is around 7 or less. So if we're sitting a little bit above that, we can look like, okay, where are our risks here? So, you had a few of these copies to suggest your choline pathway might be a little less efficient. We can build choline into the diet with, eggs, some dairy. Again, we make it nuanced, right? Because we don't want
Liver.
you to do too much full fat dairy or, full fat meat. Um, Cruciferous vegetables are a good choline source. Um, and then we also look at these biomarkers, and we knew for you, like your folate was a little bit lower. We'd like to see this a little closer to like 15 to 20. Um, and that homocysteine's up, and you had several of these copies here, and these MTHFR and MTRR gene variants. So we could say, well, we can pull in dark leafy greens and animal proteins and beans and lentils, like really get folate and B12 up. We can also look seeing some of these makes me think that your system's really going to like that already methylated version of B vitamins. So if we're kind of going more of that supplement route, we want that to be kind of a pre-methylated, um, like methylcobalamin, methylfolate as well. And I think you can even carry that into like our vitamins and micronutrients and what we really want to focus on pulling into the diet as well. And we can look at kind of what are our predispositions around these vitamins and micronutrients and pairing that with our biomarkers too. So, I think the example for you, your vitamin D was like high 30s, low 40s, something like that. We'd really like to see it in that like 50 to 100 range. We know you have two copies here, this CYP2R1 that helps convert vitamin D to its active form. You also had one around kind of like vitamin D binding and how efficiently we're doing that. So that kind of tells me like we, either vitamin D, calcium rich foods, and or like maybe adding in supplementation with that. I
Mhm.
think some other big ones we'll often look at here, like people have some of these like collagen SNPs and be more predisposed to tendon injuries and inflammation. So making sure we're building in lots of collagen rich foods. If some people are more slow metabolizers of caffeine, how do we limit that? And again, it's more about giving people buy-in. Like I'm not going to like rip somebody's caffeine away from them if I don't have to, but like talking through, the importance of some of that.
Can you go
Um,
back to the
yeah.
TMAO and explain that? I don't know
Yes.
why I didn't. How do you get that tested? I didn't have it on mine for some reason, but talk
Yeah.
about that because I know someone just asked me that yesterday and their cholesterol and risk for heart disease
Mm,
and
yeah.
choline.
Yeah. So TMAO, we get, and I'm gonna like forget some of my physiology here on the spot, but
Sorry.
there is like a bacteria mostly in our gut
If you
that
go
will come.
back before it explained it, I think on the other page, right above that, yeah,
Oh
that
yeah.
last paragraph. So there's
Yeah.
cheat notes.
So there is, and I can't remember the exact like bacteria, but when we eat foods like high in choline, um, if we have like a certain amount of population of that bacteria in our gut, it'll convert choline into that TMAO. When we get high TMAO, it can be very inflammatory, and especially again seen kind of correlated with some more blood vessel inflammation. So we kind of use that. I think we maybe didn't check like the biomarker itself isn't like in our initial panel, so we didn't have that. And
Mm.
a lot of times these will be left blank if like the chip didn't get a good read when we were sequencing the DNA. That's usually what happens if it's all gray. But like somebody, if we were working on like inflammatory states, reducing cardiovascular disease risk, we would kind of be looking at TMAO because maybe we're also working on methylation, and I'm gonna be a little more hesitant to do like a high choline diet or straight choline supplementation if we're getting high TMAO levels. Um, and a lot of times, like food, again, food's high in choline we talked about, but especially like high, we think more fish is often better. We get good omega-3s, but that can be one that a lot of times can roll into some higher TMAO levels.
Yeah, I
It's
think
a
it's
good
important to
question.
understand that and know that because I know someone that's plant-based, they're trying to avoid,
Mhm.
eating animal foods because they're scared it'll cause heart disease. And the TMAO they brought up, and then having choline and the carnitine that comes from the animal foods. I think the
Mm,
plant-based side of people scared is scaring the plant-based people to eat meat
sure.
because of this TMAO, where it's like
Yeah.
choline is in in our body and needed for a reason, and
Yeah.
carnitine for mitochondria. So, there is this, the role of choline and carnitine is so essential. So it would be really helpful to know,
Yeah.
am I at risk if I do choline supplementation or have more choline by eating organ meats and egg yolks?
For sure. Yeah, and I think again, even like we know we're still going to get some choline from like our cruciferous vegetables or dairy-based things. And yeah, it is like we do want it. It's kind of like cholesterol, like right? Like we want cholesterol. It's going to help build our cell walls and
Mhm.
help our brain function. And so it's kind of like too much or little of anything most of the time, right? Is there's got to be a sweet spot somewhere. Um, yeah, and so any big question, and this was that. I know you
Yeah, the
mentioned
nutrition. And then
the
what about
gluten
the
for you.
insulin? For me, the gluten, if we can touch on how we can see clues for that, non-celiac
Mhm.
gluten sensitivity, and then the risk for type 2 diabetes, because that seems to be on all my reports. I've done genetics, but just how more risk for insulin resistance.
Mhm. Yeah, so this I'd say to the gluten one first, we do check this one gene here, this SH2B3. This you have two copies here, so that can suggest you might be more predisposed to have a gluten sensitivity. Again, always pairing that with what are your CRP numbers doing, or we can check like a LPPLA2 that is more like blood vessel inflammation, or what are your symptoms when you take in gluten? But then also looking at, I think yours is maybe down here, these HLA variants. So there's a few of these HLA variants that could suggest like a higher or lower risk of celiac disease, or that kind of true gluten allergy and pathology. And usually, so you did not have any of the HLA variants, so that almost 100% takes out risk of having that celiac disease. But we know for you that, we still have that risk of gluten sensitivity. And
Is
so
that
pairing
on the
that,
report down there? It said the gluten sensitivity. Is that just that one genetic SNP they're looking at, or are there more other ones that they
I
put together?
believe, yeah, there are, we have this one, the HLA variants, and I believe there are a few more. Again,
Yeah.
they'll kind of pull like, a little heavier weighted ones into the report to explain. But there is like a polygenetic aspect to that one too. And then you mentioned insulin resistance. So, some of that we might see in like what's our intolerance to carbohydrates. I think you also had like this IRS1, an APOE5, you had a couple copies there. And so this it's in the fat intolerance column, but it actually can increase risk to things like insulin resistance because the way that these fats are broken down, it can interrupt some of this insulin signaling. Like it can create a like cytokine cascade that interrupts with insulin receptor, like the GLUT4, I think, and some insulin receptors. So I think some of that, we have, even though this is in the fat tolerance column, it's like higher fat could make you more likely to be insulin resistant. Like if you were to say like full, like keto, full fat. Um, and then obviously again, insulin resistance being a big polygenetic score. Um, there's a section here at the bottom about insulin resistance. So again, several genes that go into that, IRS1 being one of them. And then taking into account, I think for you, like you're very dialed in and aware of things, but I'll often see, we can explore with like CGM, but people will sometimes have like, pretty normal fasting insulin and glucose, but these higher A1Cs, and looking at, I'll see this a lot in like endurance athletes, whether, they're just getting like a long period of time of, like using up glycogen stores, we were getting a little higher blood sugar in running events or, insert whatever endurance event. And or like if people are fueling with, pretty um, like simple sugar, higher carb
I just had
things
a
as well.
thought. My thought is the A1C tend, now I know the last test it dropped down, but
Yeah, I
I
think
did
like
this
5.5.
mitochondria me screen test earlier this year,
Hmm.
and I'm not very good at oxidizing carbohydrates.
Hmm.
And so it showed to me that I'm not, so I wonder if my glucose is higher over time because I'm not very good at using
Oxidizing.
glucose for fuel when I exercise.
Hmm.
Be
Yeah.
interesting. I'll have to look at that. But why? Because it is like, why is my glucose fast? A1C says your average over the 60,
Hmm.
90 days. But looking at that trend, so I have my labs to go get new ones. So anyway, I just want
Yeah.
to share that because I think that's
Yeah.
important. And I just advise everyone to get their fasting insulin that you can order it on your own. The doctors will not test
Yeah.
your insulin unless you're diabetic. And it's ridiculous because it's a
Yeah.
little late.
Yeah. Yes.
Want to know beforehand. So we want to see that insulin between 1 and 5, right?
Yeah, and I think, I think that even the lab normal range, like, is still kind of calculated as
Up
like
to 10 or
less
something
than, I
crazy.
think it's even like some of them go up to like 15 or 20, but I, feel a lot better if we're below 10, but like that, 5 or less is going to be kind of like our optimal goal there. And I like to tell people like fasting insulin's kind of that canary in the coal mine, like we're going to see that kind of start creeping and giving us an idea of maybe some early brewing insulin resistance.
And then A1C, I know Dr. Davis says around 5. In our FDN ranges says 5.5. to
Mhm.
one. What's the Wild Health guidelines for good A1C?
Yeah, so we try to, I would say 5.5 or less. We often keep to, and I think we might officially say less than 5.5. And kind of like, but when we cross that, you know, 5.6 or, you know, I don't think any one number tells us like, insulin resistant or pre-diabetic, but we just,
Yep.
again, to like,
Put it
piques
all
our
together.
interest. We want to look into it. Yeah, for sure.
Can we scroll down to go back to the cardiovascular one? I know down
Mhm.
there's a report at the end somewhere in the
This one
cardiovascular
maybe.
disease. So this is, as you probably, Megan, your dad passing in your family genetics is looking at my risk with my dad had heart disease in his
Mhm.
60s, and then he ended up having 10 years later starting to have problems, and it was kidney issues and some type of cancer. But he had this starting. And so we want to look at genetically what markers are we looking at for genetics for cardiovascular disease?
Yeah, so again, this is one of those like, polygenic scores here. It's based on this study out of Harvard. So they took, almost 50,000 patients that had had heart events, kind of like laid out like here are the genes we think are, could have been contributory. And now we're, taking your sequence and laying it over top and seeing what overlaps. So, for you, we're seeing a lot of overlap of those genetics. What this study, and part of the study was saying like, okay, based on these genes, like, can we determine who's more likely to benefit from cholesterol control, statins, things like that? And like how will we reduce risk? Um, but what I like to the caveat I give people is, these are like just genes. The study did not take into account like any of these people's lifestyle factors or the fact that, we're sitting here trying to optimize yours. Um, and knowing that, genetics is just going to be one piece of that. So we pull in against some of these. There's a handful of genes that, again, we'll pull into this report that are the heavier hitters. The one for you, you had two copies of this ACE gene, so can have high risk of higher blood pressure. There's that like insulin resistance or diabetes, increased cardiovascular disease risk with like high fat, high saturated fat intake. So I'll sometimes show people this, like we may have, a higher chance of that even affecting even our kind of like baseline risk and not just our cholesterol number, that higher saturated fat for some people. Other ones that there's a few that, which you didn't have any variants of, so didn't pull them in, but a few others that show up here, like, predisposition to higher blood pressure with high salt intake. Some people have like those heat shock proteins may have like less efficient use of those. And that may prompt us to like add nitrates, like not the preservation kind, but like naturally occurring nitrates like beets, things like that into our diet to help with that nitric oxide production and keeping our blood vessels nice and flexible.
Okay,
Or
wait,
kind of, oh
pause.
yeah, yes.
That's my other big thing I discovered lately. They don't convert to nitric oxide if you're using mouthwash and if you have PPIs, poor stomach acid. So they convert
Mm-hmm.
nitrates to nitrites in your mouth. This is Dr. Nathan Bryan. I've
Uh-huh.
read his books actually here and interviewed him twice, but just how you can take the beads, but you have to not use mouthwash to kill off all the good and the bad bacteria. So you have to have the good oral bacteria. And then phase two, to convert nitrates to the nitric oxide is in your stomach and has to be acidic enough. And majority of
Mm.
people I see are on PPIs,
Yeah,
antacids, which are destroying your ability to digest things properly with acidic environment.
for
So
sure.
it
Yeah,
does do that if
a good
everything
caveat. Yeah.
goes smoothly.
In
Caveat.
theory, yeah, in theory. And I'll also give the plug that if maybe we're in that boat and like the dietary nitrates aren't going to help, um, sauna is another big like nitric oxide promoter, and like I think very underutilized tool for
Use that
reducing
4 days a
cardiovascular
week.
risk. Yes, yes. Get your like 4 to 7, four to
Yep.
seven days. So like that's some that show up here. And then we'll also look if anybody has any copies of factor five, where you might be more predisposed to things like blood clotting, that would show up here in this section as well. And that can be helpful sometimes, not only from a cardiovascular standpoint, but even if we're counseling someone around, like, do we want to add in like a hormone therapy or, anything else that might increase clotting risk, knowing do we have kind of extra baseline risk there can
Mhm.
be helpful. Um, and then this is kind of, so we look at the genetics piece of that, and these are some of the columns that we can control if needed to reduce some of that risk profile. So whether that's, you're somebody that might have like the higher LP little a or ApoB or, LDLP, anything like that, we check for, again, this inflammation, omega-3s. If we get that to a good level, that helps decrease inflammation. And CoQ10 can be really helpful, again, especially in folks with that higher LP little a as
I
well.
don't eat liver, but I'm doing the grass-fed organ complex and not
Hmm.
really paying attention when I'm actually taking because it would gross me out.
Yeah.
I
Yes.
just throw them down. But the CoQ10 is a good source in the B vitamins and other nutrients
Hmm.
in organ meat. But if you can
For
eat
sure.
organ meat, I think a few times a week it's helpful for that. But I rather take that in capsule.
Yes. Yeah. It's a little different
Yeah.
taste if you can encapsulate that for sure.
Not even going to try it. Even the
Yeah.
capsules taste gross. I just have to wash them down. So just the
Yes.
last little bit, because I don't want to go over your time, but
Yeah.
what other key things do we want to share that be helpful for people in the report? And then we can finish showing my
Yeah.
follow report 6 months later that actually improved all these markers.
Yes, that's right. Yeah, I think, another big one a lot of people are usually interested, like we talked about, is like around the um,
Yeah.
genetics around our dementia risk. I do like to give, again, the caveat on our report. This 96% is our confidence interval of like, we're definitely sure this is your combo. This is not your risk of getting dementia. Um, but, we know that, again, dementia can be so multifactorial. ApoE is, one of the more studied genes, and we know, like, you'd be like the green box here, like the vast majority of the population is ApoE 3.3. And anytime we add a copy of that ApoE 4, that's going to increase kind of that baseline risk. So adding a copy of, if you were like a 3.4, that would take kind of that normal, population risk of somewhere of 7 to 9% of developing dementia in your lifetime. We add a copy of ApoE 4, that could go to like 20 to 30%.
Mhm.
And so it kind of like is a little more exponential when we add in the ApoE 4. Um, but again, I always give the disclaimer, like, this is a blueprint. This does not mean you absolutely will. And these are the ways that we're going to try to bring that baseline back down toward that normal population. So whether that's, again, our methylation, optimizing hormones if able, optimizing thyroid, vitamin D, like these other micronutrients, omegas, inflammation for sure. Like, how can we reduce inflammation? So I would say biggest things around this are usually, are people active? Are we touching micronutrients and inflammation? Reducing saturated fat if needed. Biggest one, other ones being like, can we reduce or cut out alcohol, any other type, tobacco use, things like that are big ones. And sleep being you know, um, a big piece to our brain health for sure.
I feel
Um,
that most people need to start with improving their sleep before going other areas. It's
yeah,
like your body
I agree.
heals, repairs, detoxifies while you sleep. So let's get that
Yes,
habit worked
yes,
on, improved the quality of sleep first. Might be
absolutely.
beneficial.
Yeah, and I think,
Okay.
a lot of times we'll approach that as like those things, like, we're absolutely going to talk about sleep and we're going to start in on that, and we know it can take a little while too. Um, so are there things we can like, simultaneously add in for sure.
Yeah.
But yes, I cut
Mm.
you off. What was your
Oh, no,
question?
it just was I don't what else
Mm.
is on there, but I wanted to show it doesn't on the second report, it keeps the obviously genetics are the same, but the lab markers, are they updated side by side on the second report?
So
Or the
no,
M
like
by
I can regenerate this and it'll change like the numbers here.
Mhm.
Um, and so we won't always see like a side by side in this, but within the um like the chart here, we could always see, kind of flip back and forth and see, I think for you, like, that LDL came down, your ApoB came down a lot. You always had like a nice and low LP little a, which was great. Um, I was going to show
The
the
methylation,
A1C came down too.
when I'm curious about the TMAO, I should get tested next time. But the
Hmm.
because homocysteine has came down, taken methyl B, we want it under 8, but it was still a little bit high.
Hmm.
And that can be improved with the methylated B complex. But then also the role of choline, my choline one, genetic SNPs I've always seen is I always need to get more choline in my diet.
Hmm.
So it'd be interesting to look at the TMAO marker, see, okay,
For sure.
do
And
we
a lot of
choose B or
times,
choline or both?
right? And so sometimes what I'll find, whether it's like if we have a higher TMAO or somebody that's like we're trying to avoid saturated fats and some of our choline sources might be higher in that. This is a place where we'll often, if able to, gravitate toward creatine um, because it will free up more choline to be used in that
Oh,
methylation pathway.
I didn't know
And
that.
then we get like some added benefit of, maintaining our lean muscle mass and things like that. So we'll
Yeah, the
often
other
use
research on the
creatine.
brain health for
Hmm.
creatine.
Yeah.
So what'd you say? The choline, creatine helps increase choline?
Yeah, it's like it spares, and again, I'd have to like
To look
brush
that
up
up.
on my exact pathway, but it will like free up and it's like choline sparing. So it'll like free up choline to be used, more for methylation than being used up in other systems as like a cofactor and things like that. Creatine can kind of take its place.
And the AST,
And it
ALT
doesn't,
are, oh, sorry.
oh no,
Go
I was
ahead.
just gonna say creatine does not increase TMAO because we're not adding in extra choline.
Hmm. So the person that's scared of TMAO and cholesterol and heart disease, they could take creatine
Yeah.
is a safer way.
Yeah.
I'll have to look that up. Okay, so AST, ALT, those are also liver
Hmm.
enzyme markers, correct?
Yes.
And so if those are a
Um,
little bit higher, it says showing signs of congested liver. Then you can look at the thyroid panel if T4 is not converting to T3 as we were working on.
mhm.
Cholesterol is
Down
higher, that can be
here.
congested liver. Hormones.
Yes. Yeah. And I always give the
Oh,
like
look, my
little,
estradiol's I got a little bit.
yeah. Um, I always give the caveat to, again, a lot of our reference ranges, like some of them we have set to that optimal goal. So like, if you got your LabCorp page, like these 23, like AST and ALT are still like a lab normal. Um, but we're just, kind of aiming for these optimal goals here. So I would like to give that because people are like, there's a lot of red.
Uh, well,
But
people
we're
need to
sometimes,
understand when
yeah.
they get their lab results from the doctor and the lab core, whatever,
Hmm.
where you got your labs, those ranges are not optimal. They're just
Right.
normal based on sick people
Right.
as well as healthy people. So
Yes.
don't look at those.
Yeah. Um, so yeah, I know for you were watching that, we'll kind of look at them here because sometimes if our methylation is way off the charts, our liver is going to, be picking up some of the slack for some of that detox pathway and things like that. So we like to kind of peek at them here near our homocysteine. And then, yeah, for you, we're kind of working on some of this thyroid health and, you know, hormone fluctuations and all of that fun stuff
Yeah,
too.
still not in menopause.
Yeah,
People know you have to have no cycle for 12 months, and then you're one day you're in menopause, the next day you're
yes.
post-menopause. I'm
Yep. It's like one point in time.
gonna be the oldest
Um,
person still. I'm turning 54 next month. I'm like,
that's
okay,
right.
I'll be
Yeah.
my 60 years old still on my cycle.
Right. You're just sucking up all those bone health benefits though. And
Yep.
that's awesome. Yeah,
Amazing. And
anything
then
else?
CRP, I think, is something people should always look at too, because that's
Hmm.
the big one we look at for inflammation and correlate that
Yes.
with triglycerides and probably
Hmm.
insulin too.
For sure.
And
Yeah.
ferritin, because ferritin high can be inflammatory marker.
Yes. Usually pretty reactive on that ferritin, or can be, if we're getting too high. And I think, pointing about that too, we also check some of those genes. If you're somebody whose ferritin is running high all the time,
Mm.
do you have more of that genetic predisposition to like hemochromatosis or holding on to too much iron? Um, so just giving another little like a plug for how some of these genes can change what we do or what we check for
Yeah.
sure. But yeah, absolutely. I really like to trend CRP, we know it's pretty like non-specific and very sensitive, but
Hmm.
definitely as a trend gives us, a lot of insight into how are the systems running kind of hot, and how are we handling and getting rid of, different inflammation, even
Yeah.
if it doesn't always point toward the obvious source.
Then lastly, can you just share the CBC and then we'll wrap up?
Yeah.
But because I think the eosinophil part,
Hmm.
all those, how they can be given as clue, the white blood cell count, but the breakdown
Yep.
lymphocytes with inflammation or parasites and how you can get information.
Yeah, and we can definitely, depending on, what blood cell line, like you said, neutrophils versus monocytes versus eosinophils can kind of point toward, you know, what could possibly be, and especially pairing that with a CRP too, of like, are we seeing those eosinophils? Or if I'm seeing more neutrophils, I'm going to think more like, do we have some bacteria somewhere? And that can definitely give us,
And that's
some
why
little
kind of why
clues
we
as
would
well.
maybe look at the clues to GI map or a stool
Hmm.
test to look at any underlying inflammatory
Yeah.
markers in the microbiome gut.
Yeah. And I often reach for stool testing, microbiome testing, if we just have that like stubborn, smoldering CRP too. Like we're just kind of living at like 2, 3, 4, we're not really, like, we're maybe improving other things like insulin resistance and whatever, and it's not changing. Um, I'll often, you know, start to peak other places, the gut being one of the first ones. Yeah,
Amazing.
so lots
Well,
of lots of
lots of
stuff and
information.
rabbit holes. Yeah. We say we give you like a fire hose of information, and you have to like
Yeah, 'cause how many pages is the
filter it on.
Wild Health report?
It's like usually around 46, yeah, 46,
40.
47, something like that. Yeah.
Yeah. So I just think
Uh,
it's powerful information to get, and getting more knowledge is power about how to create your own precision medicine is what we talk about here, to be your best
Absolutely.
future self. And you don't know what you don't know. And so
Yeah.
this really helps figure out, should I have choline? Should I have eggs? Or
Yeah.
should I change my food plan? And what should I do for my exercise and not overtrain, and recovery we didn't get into. But I think the information you get is very beneficial, gives you power in personalizing your own program. Now, tell us how to find you and
Yeah.
where to learn
Yeah.
more.
So, and I'll, make sure you have links to everything, but just like wildhealth.com, that'll kind of get you wherever you need. Whether that's, seeing what we do. I think we have some like, sample health reports, like how to sign up, and that also should link. We still have our podcast going as well. So lots of like fun info and snippets on there, from different docs and health coaches. I think that's another cool thing that maybe we didn't even mention is like, honestly, I think outside the genetics, we have the genetics piece, but like our health coaches are the rock stars for sure. They, just help implement all this stuff and get like a good 30,000 foot view. And it's a lot of information. And like, how do we distill that and make it practical and sustainable?
Hmm.
For sure.
Yeah, definitely helps.
Yeah.
And people, if they just want the report, is there a way to just get reported, or then you only can get it through joining the program?
Yep. Usually there are a couple different like membership tiers, but kind of joining the program in some sense, with a membership kind of gets you, a lot of the membership now is including, it's kind of like morphed over the years. So we get like the genetics, but the like epigenetic testing, like the biological age, all that's rolled in now. It includes, quarterly lab check-ins, and then also incorporating in like DEXA and VO2 max now too
Oh,
with those memberships. So, um, yeah, lots of great stuff.
that's great.
Yeah, it's been
I have to
exciting.
look at what they're doing for their VO2 max testing if they're using my Pinoe stuff now.
Oh yeah. Um, yeah, but it's been really fun, and seeing how many folks are just like, optimizing and just feeling better and really getting a lot higher quality of life for
Yeah,
sure.
love it. Well, it's good to have a report and then you can see visually, oh, all the work I'm doing is actually paying off once you
Yes,
know what you need to do as a unique individual, not just guessing and listening to all these podcasts and social media posts, do this, do that. But now you can actually have plan of action customized based on your own unique body.
absolutely.
So good.
Yeah.
Well, thanks so much,
Cool. Yeah,
Megan,
thanks for
Dr.
having
Jones,
me.
and I will be in touch because I have my order to get my new blood work. So see where I
Excellent.
am.
Yeah, I can't wait to see our our trends.
Yeah. And the stool test will get my microbiome.
Yeah. Yeah,
And I
yeah.
need the Dutch test too. So ideally get all three and see what's going on. Thank
Perfect. Can't
you.
wait. Yeah, thanks for having me.